Welcome, Dr. Hemraj. This will be a type of a mock test for EDIC 2. What is done in I'll try to replicate it exactly what happens in the original exam. We'll be dividing this exam into two parts. The first will be the CCS, a case will be there, and the CBS. I think you must be aware regarding how the case goes and what are
Yes,
the
sir.
paper
I have. Yes, sir.
Viva.
I have given the exam 2 times, sir, before also.
Okay. So you know everything. No need for me
Yeah.
to explain that.
Yeah. Sure,
That's
sir.
very nice. The first vignette I'm showing you, you can read it out, and when you complete, you let me know. I'll start with the questions. Okay.
Sure, sir.
So this is the case.
Yes, sir. I have read it.
Okay. These are the investigations. You can have a look.
Okay, sir.
Okay. This is the ABG.
Yes, sir.
Okay. So my first question to is, please summarize the findings in this case, the positive findings.
So, sir, this is a male patient with known liver cirrhosis, and he already had an history of variceal bleed. And this time also he has this has all admitted with decompensated CLD, sir. And maybe this patient is having ascites this time. So maybe spontaneous bacterial peritonitis could be one differentials for admission. Maybe coagulopathy, INR is high, and the third thing is that patient may be having HRS with decreased urine output as the patient is having acidosis, and maybe hepatic encephalopathy, sir. We have to see for the neurology.
Okay. Any comment on the blood gas? What was
So
that?
patient is having severe metabolic acidosis, sir, right now, along with the respiratory acidosis. Maybe the patient is drowsy and retaining CO2 along with the.
Okay. What
With sub,
immediate management does this patient?
we Yeah. So, sir, if the patient is too drowsy, then we have to intubate the patient. We have to ensure that he passes motions 3 to 4 times or more than that. If the patient's serum ammonia levels are high, sir, we need to we have to see for the coagulopathy also, sir. If the patient is bleeding again because he already had an history of varicose, so upper GI scopy should be done. And sir, correction of coagulopathy should be done if he's bleeding. Starting off, sir, vasopressors if the blood pressure is low with terlipressin of drug of choice, sir. And maybe need to transfuse the blood products also according to the sir TEG or ROTEM, whatever we have.
Okay. How will you classify this liver condition currently?
So, sir, he's already, sir, cirrhotic patient with liver cirrhosis, and right now he's in acute on chronic liver failure, sir.
Yeah.
So ACLF is the right now he's on ACLF.
Yeah. Any
Liver,
can you classify which classification you used to
sir,
uh,
West Haven classification is for hepatic encephalopathy. The
no, for
King's
the
College
liver
criteria.
condition?
Sorry, sir.
For the this liver condition, for this acute liver failure. So how can you classify it?
Sir. So we have sir childpox criteria, and
Okay.
there is MELD score, sir,
Okay.
for transplantation. What we classify the patient for patient.
Yeah. Good. Why is it important to classify liver failure?
Sir, to prognosticate the
Very good.
patient's current condition and to plan for the future if the patient is readily ready for the transplantation or not, sir.
Okay. What are the etiology of acute liver failure?
Sir, it can be sir sepsis bleeding from bacterial peritonitis. Patient can have acute liver failure secondary to bleeding, sir. And decompenses any infective etiologies could be there, sir, hepatitis or viral. The drinking alcohol consumption. Um, And sir, acute etiology of acute liver failure. Okay, sir, the paracetamol poisoning is very known, sir.
Yeah.
Infective like hepatitis A, B, C virus. Uh, Sir, secondary to drugs It can be done, sir. The tubercular drugs can be the reason, or the antiretroviral therapies could be the reason. Any toxins could be the reason for acute liver failure. Um, and
Okay, fair enough.
yeah.
What is the pathophysiology of hepatic encaph in ALF?
Sir,
Why discuss?
the ammonia, whatever it is absorbed from the gut, is bypasses the liver and goes into the brain directly to the from the circulation, and it got collected in the astrocyte cells, and it causes cerebral edema, sir. So the patient is having cerebral edema due to the hepatic encephalopathy, sir.
Any more thing which causes hepatic encaph in
Sir,
ALF?
bilirubin, high
Ammonia, you
bilirubin.
said it's okay. Any more?
Yeah, sir,
Any?
high bilirubin levels, sir.
Okay, okay.
Uh,
So, what is the role of liver protective measures? N-acetylcysteine, branched-chain amino acids, and lactulose.
sir,
There is a role or not? Yes or no?
sir, no proven role in chronic liver disease, but may be beneficial in acute, sir, acute liver failure.
I am asking
As
about
such,
the three, all the three.
sir,
About N-acetylcysteine, whether yes or no.
sir,
In acute,
not proven, sir. Not
we are talking at present, Dr. Hemraj, about the acute liver failure. This was a CLD patient. Now he has decompensated and come as an acute liver failure to us.
sir, sir, acetylcysteine, sir, we can use, sir. 5 days we use 9 gram per day.
And
We can
branch
use,
chain amino acids,
sir, not proven Lola, and sir, though
lactulose,
yeah, it can be used, sir. Branch amino acids can be used, but no proven benefit, sir. Lactulose,
lactulose.
sir, should be used to ensure that the patient is passing enough motions and the ammonia levels are decreasing.
No, I see the question is very
Role,
specific.
role.
Yes or no?
Sir, beneficial but not proven, sir.
Okay. Okay, fair enough. So the next minute, the patient is now transferred to the ICU, septic screen is done, and the ascitic tap is planned for this patient.
Yes, sir.
Okay. So my first question to you is, describe the process of carrying out an ascitic tap. Can you describe in
Yes, sir.
brief? Mm.
Yeah. So, sir, we can, sir, we look for the coagulopathy, and if correctable measures can be taken to correct the coagulopathy, we will correct that. We will identify the position of the more of the ascitic fluid, sir, under USG guidance with the sterile technique, sir. After giving local anesthesia, we will guide the needle, and we will tap the fluid, sir.
Okay. What test should the ascitic fluid be sent
Sir,
for?
ascitic fluid should be sent for the normal cytology, malignant cells, sir. Routine microbiology like cell count, LDH, sugar, protein, sir. And along with that for gram staining, sir. And culture should be sent.
Okay, very good. How would you diagnose SBP on the basis of
Uh,
test result?
Sir, so SBP is classified as more than 250 of polymorphonuclear cells, and along with that, culture positive should be there, sir. If
Okay.
the culture is negative, then it is known as
How would
culture
this
negative.
differ? How would this differ in tuberculosis ascites?
Sir, tuberculosis ascites will have a ADA positive, sir. ADA of more than 30, I think, is positive for ascitic fluid. The color of the tubercular fluid is also a straw color rather than the ascitic fluid, which is a little lighter than the normal hepatic, sir, liver
Any
fluid.
more specific finding in the cells in
Uh,
tuberculosis?
Sir, ADA will be positive, sir.
Yeah,
Adenosine
that
deaminase.
okay. Now the next minute, the patient has an ascitic white cell count of 1800. Diagnosis of
Yes, sir.
SBP is made,
Yes, sir.
and the patient is commenced now on piperacillin tazobactam
Yes, sir.
for that.
Yes, sir.
And my next question to you would be, what further investigation would you consider in this patient now? Now SBP we are diagnosed in this. What further investigations patient is deteriorating? What more you want to do?
Sir, we will send the cultures also, sir, blood culture, the
Yeah,
normal routine investigation, sir.
yeah.
We will send for the urine culture because source of sepsis should we know. Uh, Else, uh, investigation specific to what? Sir, we can do, sir, CT scan if the patient is drowsy to see for the cerebral edema. Anti-edema measure should be started for this patient. And
Okay, okay, okay. Uh, You can read this minute for a
Yeah,
minute.
the patient has an abdominal POC. This reveals a liver with severe cirrhosis and no evidence of hepatocellular carcinoma or portal ventral. Okay. Kidney and the patient.
क्लास चल रही है मैं आधे घंटे में फोन करूँ.
The patient has a baseline creatinine of 74 micro, which is now vasopressor requirement to increase. The acidosis continues to worsen. Yeah. Yes, sir.
Okay, so patient is worsening. My
Yeah, yeah.
next question to you is, what are the likely causes of AKI in this patient?
Sir, it could be, sir, hepatorenal syndrome. Can be sepsis induced also, sir. And it can be compression of the renal vessels secondary to the ascitic fluid as an increased abdominal pressure, sir. It could be ATN also due to the toxins released from
Any
the
more, any
bacteria.
more very the most common cause of AKI?
Sepsis, sir. And sir, pre-renal also. It can be
Yeah,
pre-renal. The
you
patient,
should say that one first, no?
yeah,
Okay,
it
good.
can be.
What are the diagnostic criteria for HRS?
Sir, the patient should not have previously raised creatinine levels. Patient should not be on any medicines which can be nephrotoxic. Patient should no have any confounding factor which would lead to the rise of creatinine. And if the patient is having liver failure, along with that raised creatinine, it goes in favor of HRS.
Okay, fine. How will you manage hepatorenal syndrome?
Sir, patient should be given sir albumin along with the terlipressin, sir. And
Anything more?
if patient may require, sir, CRRT and renal replacement therapy.
And if
Diuretics.
doesn't control with this,
Sorry, sir.
if the hepatorenal syndrome doesn't control with these
Sir,
measures,
the patient may require, sir, liver transplantation. If,
you
fine.
should say all the treatment. Okay, okay.
Okay, sir.
What are the characteristics of patient with acute liver failure which warrant liver transplant?
Sir, patient having refractory ascites, sir. Patient's coagulopathy is not improving. If the patient's uh, jaundice, like bilirubin levels, are not settling in spite of the patient on CRRT. And
Is there any specific cutoffs for this coagulopathy and things which,
sir, there's King's College criteria for liver
yeah, we
transplantation.
have such a good
Yeah,
criteria for
yes, sir.
this.
Yeah. King's College criteria. If the pH is less than 7.2, INR is more than 3, and a creatinine level of more than 3.2,
Okay,
so we should consider patient for liver transplant. And I think
very
male score is more than 10, then
okay. Okay, fair enough. What alternate criteria are there for risk prognostication in acute liver failures?
for risk.
For prognostication in ALF.
Okay.
Any specific criteria, name of the criteria?
Uh, Sir, West 7 classification is for hepatic encephalopathy. Risk criteria for risk prognostication.
For
Sir,
prognostication. Hmm.
mild staging is for that.
Yeah, MELD is there. Any more? Any more I'm
Uh,
asking. MELD you already told.
uh, Modified now.
Yeah. Okay. Okay. Yeah. Are there any specific disease-oriented therapies in acute liver failure?
There is oriented.
Patient having any specific therapies for which is causing the acute liver failure and you can correct.
Sir, yeah, sir. Secondary to AR, sir, secondary to any tropical infection. So if we can treat
Yeah.
the tropical infection like dengue, malaria,
Yeah.
and
Others, any other?
any scrub typhus, sir, scrub leptospirosis. Or, sir, patients, if the patient is having hepatitis viral infection, then antiviral should be commenced on.
Yeah.
And maybe if it is maybe, sir,
Okay.
amoebic infection, then we have to drain the that obstructive.
Okay. Okay. Fair enough. What is the role of steroids in ALF? Will you give yes or no?
Uh, Sir, No proven role, sir. Steroids should be used only if the patient is having severe refractory shock secondary to volume resuscitation. Then we can use steroids. As such, there is no role of steroids in ALF.
Yeah. Okay.
Only if the patient we are suspecting that there is autoimmune hepatitis, then we can start on steroids, but only
Yeah.
after proven on the biopsy only, sir.
Okay. Okay. Autoimmune.
Yeah, sir.
So, should we go ahead? We'll go for
Yeah,
the
sure, sir.
CBS.
Yes, yes, sir.
Performed well on the CCS. This is the CBS. Each CBS 5 minutes. I'll be taking 5 questions are there. If you finish those early, I have one more bonus question. So six
Sure,
questions
sir.
are.
Sure, sir. Sure.
Okay. We'll start with the curves. So
Yes,
the
sir.
first question is you can read and tell me the answer. Okay.
Sure, sir.
This
Sure. List three measures that are used to manage the condition indicated by the following. Sir, I think these are the hypothermic Osborne waves, sir. We should rewarm the patient. This is the Osborne wave, and we should rewarm the patient. We can give warm IV fluids. We can use warm blankets, and we can use warmers also, sir. And if we're not treated by
good.
that, then we can go for
Next.
CRRT. The patient
Next.
is
Next.
the patient typhoid 0.9 plus water type of suggested by the 20 का पीप है पीप is 20 80 CO2 is. So the patient is having, sir, some sort of ARDS right now, sir, and with the high PEEP, we can, and that patient is having high PEEP with the low tidal volume and the high ETCO2, sir.
Can you think about anything else in this? Very specific things are shown in this.
Sir, peak
What is the
pressure, sir.
question? You just need to answer what type of pulmonary deficit is suggested in this, and what are the causes of it.
Well, sir, but sir, low minute ventilation, so we have to increase the tidal volume.
Okay, next one.
List cause comment the arterial entry. Sir, test will you use? Sir, we will use a flush test to identify the problem, sir.
Okay.
And what are common causes for this? Sir, maybe the line is over damped, sir, right now.
Okay.
And we should check the pressure in the pressure bag. We should check for any air bubble in the line. We should check for the clots in the line, sir. We would a square test, flush test we will use to confirm that finding. By the image, what are the technique? The sir, image is not clear. Idle one. So the words are not clear. TV.
I don't need to go in too much into the words with this two images what they are showing. The blue one and the pattern is seen. You can identify if you know this.
Uh, dynamic. No, sir. Sorry. No idea. Comment on the report of post process like hydrogen. So our time is little high, so and MA is 54 and lysis is so sir the patient is having a little high reaction time, so we need to give cryoprecipitate or FFP to that patient's factors to the, and maybe he will require some platelet also, 4 RDPs, 4 unit of RDP.
So
No, no,
for
no.
this
Maximum,
patient,
no, no,
you'll
no,
give
no.
cryo and platelet.
No, no, no platelets, sir. Maximum amplitude is 64. Only cryo, sir.
Cryo.
Yes, sir. FFP or cryo, whatever is available.
Okay. Last one.
Comment on the red form shown. So this is, sir, pulses bispheriensis and double notched arterial waveform, sir.
Can you think of anything more?
Sir, this is a IAB. It can be, sir, IABP curve also, IABP graph also, sir, in which there is a increased diastolic volume, sir, and diastolic. What are the hemodynamic changes that occur? Okay, that occur with augmentation. So, sir, there is an increase in diastolic volume, sir, and diastolic volume is increased, sir, which increases the coronary perfusion, sir.
Okay. Last
Uh,
one. How do you time the augmentation?
sir, sir, inflate at the bulb should be inflated at the at diastole and deflate at the systole, sir.
Okay, done with the curves. Done with the curves. Next, images. Okay. Your time starts now. Okay. This is the first one.
The lady was crossing busy road when she was hit by car. Her main injuries were severe traumatic injuries. We were asking, ICP 30, list your possible management strategies. So this patient is having some right-sided frontotemporal bleed, sir, and there is a perilesional edema, and with loss of gray-white differentiation, and
Dr. Hemraj. Dr.
yes, sir.
Hemraj,
Lift your
you should concentrate only on the question. Whatever you describe, it will waste your
sorry,
time.
sir.
List
Yeah, yeah,
your
got it. Yeah,
possible management strategies. I
yeah,
don't
sir.
want what the CT is showing.
Sir, the patient should be well sedated, intubated, and well
Good.
sedated, propped up, elevated, sir, bedside, 30 degrees, 30 to 45 degrees. We should start with, sir, anti-edema measure like 3% NaCl or mannitol. We should start on the patient on uh, relaxant if the patient is working. We should consider, sir, hemicranectomy if the ICP is not coming down.
Good. Next.
What is the most common cause of principal and non-PTC? This is scan. Sir, there is calcification in the pancreas, sir, in the tail and the head of the pancreas, sir. And along with that, there is some collection around, sir, liver. There is dual, sir, two densities can be seen in the liver, sir, also. So it could be a sir, some collection around the liver also.
My question to you is, what are the causes of this? I don't want to know what is shown in the CT scan.
Okay. Sir, hypercalcemia could be a reason, sir.
Anything more?
Uh, hypertriglyceridemia, sir.
Most common causes you missed of
Sir,
this.
gallstones.
Yeah, this is pancreatitis. You should say
Yes, sir.
gallstones and alcohol and the next two. You
Yes.
see, please concentrate what the question is. No need to describe. You will not get any mark if you describe this CT scan.
Yes, sir. Yes, sir. Right, right. 69-year-old patient has been started on CVHD following an admission. So the ED, acute, acute on Crohn. The patient has been hypolymphatic with aggressant. Despite several internal fluid channels, there is no fever in the patient might be exposed. The echo is performed to try to clarify the cause of hypertension. Still, image of the subcostal view is seen. Pathology is not. Sir, there is some sort of pericardial collection is there, sir,
Okay.
and it can be secondary to coagulopathy, sir. Maybe secondary to acute MI leading to a ventricular rupture, sir, and it can be secondary to any inflammatory disease also, sir.
Any more can think of in this patient? Very clear cut given in the history. What is the cause of this pericardial effusion?
Yeah, sir. It can be fluid also, sir. Secondary to
You
cardiorenal
should,
syndrome,
you
sir.
should, you should say the most common one na, first.
Yes, sir.
Next.
36-year-old patient is day 5. Go to ICU. Following witness call at the city brain short of fissure grade 3 subarachnoid. His level of function deteriorated for central noxious to extension of CNS people to active. His EVD does not appear to have increased in the above. The following investigation is performed. Or test investigation. So, sir, The investigation is a transdoppler, sir, transcranial Doppler, sir,
Okay.
and it demonstrate the velocity is around 260 and depth is at depth of 65, sir. So velocity is in, sir, so there is some sort of vasospasm due to which the velocity has been
Very good.
increased, sir.
List three management options.
Sir, we should, sir, continuing nimodipine for, sir, intra-arterial thrombolytic, though, sorry, arteriodilator can be used, sir,
Okay.
using
Three.
a
One more.
yes, sir, decreasing anti-edema measure, sir,
Okay.
and nimodipine, sir.
Next.
This patient presented with dyspnea and required intubation for respiratory distress. The intubation was difficult at any pause for these events. Sir, there is a deviation of trachea to the left side, sir.
Okay.
Tracheal deviation is on the left side, in which we can see the tube also. Tube is going from the left side.
The question is, what is the cause of the difficult intubation?
Sir, it can be a mediastinal mass or retrosternal goiter compressing the trachea on the left side, sir.
Last one.
Identity, sir. Sir, it is optic nerve sheath diameter measurement, sir.
What
ONSD.
is the clinical usage?
Sir,
Why do we do it?
to measure the ICP, sir, make to
Biochemistry. Next. This is the first one.
59-year-old lady on the ward has recently for painful activity. Police raised on she got up to use bathroom first, the police has not approved blood pressure, what therapy would be next? Yeah, so sir, we will start vasopressors for her, sir. She is not improving with the first intravenous bolus for blood
Okay.
pressure. Sir, we will ask for the
Some specific test which will give you the diagnosis in this case.
sir, serum cortisol level, sir. Hyponatremia with hyperkalemia. And
Next.
sir, diabetes insipidus, DI.
Okay. Anything you want to specify? Which diabetes insipidus?
Sir, central diabetes insipidus.
Yeah. Next.
25 admitted to your ICU heavily sedated. Significant head injuries here, just started from the operating. Yeah. Sodium is 150. Oxygen is low. Fluoride is high. Okay. So, sir, he must have been given a mannitol, sir, in the OT during the craniotomy, sir.
Okay. Very good. Next.
Rest are just a oncology patient who recently uric acid is 0.49. Potassium, sir, tumor lysis syndrome.
Last one.
Eurostar is concerned about a patient in the unit who is proving difficult to wean from ventilators upon the patient who has multiple small bowel fistulas. Several reasons for significant study pain could continue for 2 to 3 weeks. That has been settled for some time and now the negligible patient has declared. There is no other place for the just to see the position. So 32 is actually 98. So 38 what you are shown the most recent results. What is your response, sir?
I'll show you the blood results. Okay. You
Yes,
read this?
yes, sir. Sir,
These are the
can I
blood
take,
results.
sir, can I take one call, sir? 1 second.
Yeah,
राहुल हेमल को वो दिखा दो, हेमल को दिखा दो. आई एम लिटिल बिजी. हाँ 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 हाँ. अर्जेंट है तो हेमल को बोल दो प्लीज. सॉरी सर. हाँ.
no problem.
यस सर. यस यस.
Do you want to see the results, blood
यस सर.
results?
यस सर.
These are the results.
यूरिया क्रिएटिन पोटेशियम osmolarity is high. CO2 is 154, CO2 is okay. So, and bicarb is 28. Yes, sir.
Okay. So what is your response on this, seeing this investigation?
Sir, the patient is sir, somewhat retaining the CO2 still, sir. Patient is having respiratory acidosis, sir.
Mm,
So maybe we need to, sir, the patient may be having some ICU acquired weakness also, and we may need to focus on his diaphragmatic movements and more of the physiotherapy, sir.
okay. Okay. Okay, Dr. Hemraj.
Yeah.
Done with
Thank you.
this. Thank you. Performed well. You need to only one my suggestion is to you just need to concentrate on the question. In CBS, it's not always that you are asked regarding the image or the curve or the investigation you are being shown. You have to concentrate only on the question. No need to explain the CT or X-ray. You, if they have asked only what are the causes, even if you don't say the diagnosis, you tell only the causes, you'll get the marks.
Sir, one thing I want to say, sir, that they always give the reports in both the units, sir. Like
Yeah,
the blood revision.
now that has happened since few years. Now
Yes, sir.
this is the mock exam. We wanted to make it a bit tough. You
So
will
because
get
the
the
unit.
all the reports in both the units, and also the abnormal reports will be in the red.
Yeah, yeah, I know, sir. Yes, sir.
So the it would be a bit easy. But this is a practice session. That is why we are keeping it a bit tough. Don't worry.
Sir, because that was taking a time reading the units and KP and the
Yeah,
micromoles per
yeah.
liter,
Now,
so that
now,
was
now,
making that.
now they have done that. Now they have done that. A few years back, this was not the case,
Yes, sir.
but since few years they have done that. You will get all the reports in red, and it will be in
Yes, sir.
both the units, so that
Yes, sir.
you get some more time in biochemistry.
Yes,
Yeah.
sir.
Okay, Dr. Imraj,
Yes,
thank
sir.
you. Thank you.
Thank you, sir.